let's get started. So the objectives for this talk are to review initial management of a patient that has a high probability of multiple devastating injuries, and discuss how integrating a multidisciplinary team into scenarios like this can be helpful, and kind of tricks for activating people in the best way possible. So the history we got on this patient is a 44-year-old female. Fall from 7 stories. GCS at the scene was 15, reported by EMS to be hypotensive and tachycardic. So on arrival, this is what we saw. So to orient the patient, head is kind of up on the left side, and head is to the left on the right side, with the extremities sort of folded back over the upper body. So primary survey, she was protecting her airway. She was speaking to us, had bilateral breath sounds a little bit decreased on the right, but satting okay. Blood pressure was in the 60s, with heart rate vacillating between the 120s and 140s. GCS 14 and the fractures that I'll just go back to here. So that was our first thought. Our kind of first pause point is, what would everybody think about doing next in this scenario? Any takers?
Would you like to call on the panelists so they can address as you call upon them?
Sure. So who wants to who should I be calling on? Who wants to step up first?
I can help, John. You guys can hear me okay?
Yeah.
Let's see, Dr. Kasim, Dr. Untract, Dr. Carter, Dr. Valenzuela, Dr. Martos just joined. So just if you agree, Dr. Kasim, Dr. Untract, Dr. Carter, maybe Dr. Valenzuela as well, to provide some commentary. I'll start with Dr. Kasim.
Well, this is an unfortunate contorted body of a female. Fortunately, she's verbalizing. She's made way. That tells me that she has much of a head injury, because she is able to verbalize, and so I don't have to get terribly concerned about an airway. Looking at the body and looking at what I see, she has probably multiple fractures here and there. Each of those fractures can lose substantial amount of blood. And they say that if you fracture your femur, you could lose as much as 3 liters of blood. No wonder she is hypotensive, tachycardic. So we need to establish proper IV infusion therapy. It's all available. You should probably resuscitate her with O-negative blood, and at the same time send off vials of blood for tap and cross match. Maybe having the MTP initiated. So circulation and maintaining an adequate blood pressure of 80 would be important in a patient like this, and then we'll go from there. Thank you.
Thank you, Dr. Kasim. Dr. Untract, any comments?
Yes, I agree with what Dr. Kasim said. And as you said in the title, devastating injury. So she's in shock, but she's awake and speaking to you, controlling her airway. So the priority is airway, breathing, circulation. Apparently, she seems to be breathing adequately if she's able to speak to you. So she needs 2 large pore IVs, massive transfusion protocol. I agree with starting the O-negative blood. And she's 41, did you say? Did I have that right? The age right?
44. 44,
44,
yeah.
okay.
Yeah.
So, yeah, she's kind of getting toward the end of childbearing age, but I would still, if it's available, give her O-negative blood. And then while she's awake, ask her if she can wiggle her toes or move her lower extremities, but looks like very severe fractures and probably other internal injuries, you have to assume. And then I would, you need to immobilize her neck. I couldn't tell if she had a collar on.
She does.
She does not.
She did. It's flipped up to put the subclavian in, but she does have
right. And then okay, and then I guess her back is exposed in the photo in the upper right. Examine her there, roll her flat, and then carry out an EFAST exam, Foley catheter, EFAST exam, 2 large bore IVs, and determine if she has internal bleeding. I suppose she could be in shock just from fractures of the femurs, and then along with that, immobilize the extremities to stabilize the fractures. But after that, she needs to go fairly quickly to the operating room.
Yeah, and I think that we put an introducer in immediately, and I think this is a pretty good example. There's some stuff coming out about the C coming first. And I think in this case that, that decision was fairly easy. She was obviously hypotensive, but was protecting her airway and able to talk to us. So I think getting access, getting blood started, she actually did randomize to a study of PCCs. So she also got that up front with her MTP, but that is what we did. We put a subclavian introducer, got IV access, and her blood pressure did start to recover immediately with transfusion. So on secondary survey, we did the FAST. That was immediately positive in the right upper quadrant with significant fluid in the abdomen. And at that point, obviously she has these fractures. We decided not to do a chest and a pelvis because we were going directly to an operating room. So how would you approach this patient in the operating room? And we've led you there to this point. So we avoided intubating, avoided sedating the patient till we got her back to the operating room. But what would your initial approach be? As we can go with whomever.
So
Probably looks like he's got the lineup.
If I may,
Yeah.
I would have approached this a little bit different. And I am a guy who really doesn't like to intubate patients in the emergency department because you lose the sympathetic discharge and sometimes they become very hypotensive. They're difficult to recover. But this patient has potentially too many injuries for me to go straight to the operating room. So she can have from everything. Obviously, she has sensation, so the spinal cord appears to be intact, but she can have an aortic injury. She probably has multiple pelvic fractures, spine fractures. So I think she needs to be intubated so you can reduce the fractures and get a chest X-ray at the bare minimum. And if hemodynamically stable is a patient that I would probably scan, if she's responding to the fluid, because you don't know what you are dealing with. So this is, I would do this a little bit different, but that would be my approach, which is probably wrong because Dr. Untra and Dr. Kasim went different way.
Actually, I didn't go a different way. I just started with a fee, and that's where I would start. But I totally agree with you, Dr. Huffman. I totally agree with you.
And
I'll give
so
other people the
Would anybody like to chime in and tell us what they would do? There are other participants available.
Yeah, Dr. Calderon Zapata, would you like to make any comments?
Yes, good afternoon. I'm post call. I apologize if you hear me drowsy, but at least I would like a little bit of more information. Speak about images. At least I would like to have a chest X-ray and the abdominal ultrasound and a pelvis X-ray, because I already know that both lower extremities are very shattered, smashed, and they might be a source of bleeding. But I need to know about these images to have a further idea of where to approach first in the operating room, either through the abdomen or to, or does he need a thoracotomy? Yes, we have a positive abdominal fluid in the abdomen, but what about the chest? I need a chest X-ray or at least an extended fast. We have that information. Thank you.
So I will say we did do an EFAST, and it looked like there was a probable pneumothorax on the right, but it was a little hard to tell. Honestly, her legs were in the way of kind of getting good views. But what we ended up elected to do is go straight to the operating room, and as she was being RSI, we just put bilateral chest tubes into the right, and then the left chest did get air and blood out of the right side. And then shortly thereafter, the orthopedics was in the operating room with us, rapidly reduced the legs, prepped the abdomen, groins, all the way down. So that's how we decided to approach it. But I think this is a good discussion. I think it's, it would have been reasonable to consider a CT. And to be fair, she was transiently responding to fluid. So by the time we were ready to roll to the OR, we had her systolics over 100. So you could have argued at that point to reduce these in the ER and get more information. But I think with a positive FATS, I do think all roads were going to the OR, being that hypotensive, and with a positive FATS. I don't know if Dr. Carter wants to chime in.
Yeah, I'll speak up. And this is my patient, so I have the benefit of knowing ultimately what her injuries turned out to be. But, that height of a fall, the lethality is so high that when she presented with a blood pressure of 60 and this obvious large fluid stripe in her Morrison's pouch, I concluded that she was at risk of, immediate death from hemorrhage, and that if she was going to survive, it was going to be in the operating room with her abdomen packed, and then addressing the rest of what I was sure would be many injuries. So instead of waiting for additional imaging in the emergency department, I felt like moving back, getting her intubated, the legs reduced, bilateral chest tubes, and abdomen open and packed was going to be the fastest route to hemostasis.
I have a question for Dr. This is a deceleration injury, and there is a possibility she may have an aortic or the transaortic tear. And so something that I would be concerned about for putting Exol in the abdomen.
Yeah, that's a very good point. And you're right. Given her mechanism, I basically assumed that she would likely have some type of blunt aortic injury, but I thought that was unlikely to be, or less likely to be, what was immediately killing her, given the impressive fluid stripe on her abdominal fast. And I felt that she was unlikely to benefit from going straight to TVAR. So if we operated on her and she was still in shock after packing the abdomen, we would have the chest tubes in. If there was excessive bleeding from the left chest, we would open her chest. And then if it wasn't bleeding, then it probably wasn't what was killing her at the moment. So, it's a calculated sort of balancing of the risks. Absolutely, she's at risk for that injury, but I thought it was less likely than abdominal bleeding to be killing her at the moment.
I agree.
All right, so from there, we proceeded to XLAP. So did find blood throughout the abdomen, seemed to be coming worse from the right upper quadrant. Took down the falciform, sandwich packed the liver, packed all 4 quadrants, and even with packs in place, there's continued subhepatic bleeding. So I think this for a learning point for everybody. How would people proceed from here?
Let's
A
go
learning
back.
point for the trainees, I should say.
Yeah, absolutely. Dr. Untrack, do you want to make any comments here?
It's continued subhepatic bleeding. That's worrisome for retrohepatic bleeding. You mean retrohepatic bleeding or bleeding?
It was, the liver was kind of cracked pretty good, so it was coming out from kind of below the liver. That was our initial thought as well. this is
Right. In other words, bleeding from the liver appearing below the liver. So I'd be
Yeah.
concerned about subhepatic bleeding, either from the hepatic veins or a retrohepatic vena cava. So if it seems to be coming from there, I think you need to assume that that's what she has. And then the approaches are for that bleeding, if that's really what she has, and that would kill her before a contained rupture of the descending aorta. So the approaches are to do the 4 clamps and then mobilize the liver to look, or what Dr. Supa in Bangkok has used multiple times, works well for him, is to extend the laparotomy incision into the lower right chest, so you can get control of the retrohepatic IVC, and whichever one you feel comfortable with, I would go to first in this case. It's but you need to get control of the retrohepatic vena cava and also the hepatic veins. And I assume it's venous bleeding that she has, right?
Seemed to be venous bleeding. Yep. And so what we ended up doing first is actually putting a Pringle on, just to start with. And putting the Pringle on actually did slow the bleeding down fairly significantly. So at that point, we were a little happier that we weren't dealing with a major IVC tear. She did become hypotensive during this, so we had some manual supraciliac aortic compression and allowed anesthesia to catch up here. IR was already aware of the patient, but we did ask them at this point to come into the operating room. And with the Pringle on and the lessened bleeding, we elected to take care of the large laceration in the liver. There's a picture of it on take back we can look at later, but we weren't taking pictures at this point, unfortunately. But we're able to mattress the large laceration, and then given the Pringle had controlled the blood and we kind of got the liver pushed back together, we decided to repack and come off Pringle, which was hemostatic. So at that point we got lucky that we weren't dealing with the big bed. It's what sort of was the discussion I was trying to foster, but we got, I think, a little bit lucky here. I don't know if Nick wants to chime in here.
No, I mean, I was very, very grateful that the above interventions worked, and right upper quadrant was hemostatic at that point.
So-
one thing that you can do if you suspect, and it's very counterintuitive, you have a big liver injury, patient is bleeding, you do the Pringles, continue to bleed. You have to stop the resuscitation. You have to let the CVP fall below 5, and the bleeding will decrease significantly, and that will give you some room to be able to fix this. And it's very counterintuitive because you're fighting anesthesia that want to give fluid because the patient is hypotensive. And the other thing, which I think is the beauty of this conference, when Dr. Supa presented this, which I never saw described before, is to extend the incision, as Dr. Untrak mentioned, through the intercostals, and he had the wonderful picture with excellent access to the retrohepatic IVC to repair it. So those are things to consider if it's a real retrohepatic IVC injury, which was not the case here.
Thank you, Dr. Hajma. Great. Dr. Calderon, again, any comments?
No, that's fair enough. So packing didn't work. So next step is to do the Pringle maneuver, and well, it slowed down the bleeding. Otherwise, if it didn't, you will have to do the hepatic exclusion that I have never seen before, only in books. And besides that, excellent presentation from Dr. Supa. So far, you're doing what you have to do. No more comments. Thank you.
All right, so the next steps, we went to the operation. The spleen was unpacked, no significant bleeding, actually, just a capsular hematoma was repacked there. We then elected to explore the retroperitoneum. No zone 1 or 3 hematomas at this point. There was a zone 2 hematoma kind of near the sweep of the duodenum. At this point was not expanding, was soft, given the blunt injury and her continuing to be hypotensive prior to dealing with the liver. We had a debate about what to do with this. So that's a next. How would you approach a zone 2 upper hematoma near the liver in a blunt injury? Would you guys? I know the book teaching is blunt injury, not expanding, don't explore. Would any of you guys have explored that or no? No. Looks like that was a pretty straightforward answer. So we'll just we'll keep rolling through that. So we did not explore it. We ran the bowel, had several contusions to the mesentery in the bowel, but no mesenteric tears, and nothing on the bowel was devitalized. At this point, we did place a Foley during the case that had gross hematuria. But at this point, we had gotten to a spot where we had no active transfusion requirement, but was still profoundly acidotic. So we did not, or I guess another pause. So how would you approach the gross hematuria?
Start with you, Dr. Untrack. Do you have any comments?
Well, you know, if you said there's a little hematoma around the duodenum, but not around the kidneys, and if the urine output continues to improve, I would just watch the urine output, and in addition, if she's acidotic, I don't know what her temperature is. I assume she's not overly hypothermic, or was she?
Not overly at this point. The transfer was pretty quick. She was a little bit hypothermic, but
right. So I would, if the orthopedists are there, have them stabilize the fractures temporarily, get her out of the operating room into the ICU, resuscitate her, and then at the first opportunity, then I would do the CT scan.
All right.
Thank you. Dr. Kasim, any comments?
Well, at this time, you have got reasonable control of the abdomen, but you cannot ignore all the other injuries that she may have, and from which she may continue to bleed till you take some proactive action. So I don't know have you reduced those fractures?
The legs are, they're reduced and flipped down, but that actually leads us into this next part.
So did you check the ABI on both sides to see if there was any vascular injury?
So we didn't do ABIs at that time exactly, but what we did do is get signals back. So when the legs were reduced, there were signals back in the DP. So we did actually ask IR to come in and shoot an aortogram, as well as multiple imaging of the liver, kidneys, make sure there was nothing that they could do on table right at that point. And orthopedics also put X-fixes on. As you said, the legs were pretty wiggly, which is not surprising with the amount of fractures she had. And they would get into positions where you would lose the signal, but straightening them out got you the signal back. So at that point, I tried to get Cines here, but I just put this up because there's a lot of packing material in the way of kind of all of IR's interventions, or all of IR's angiograms rather. So I gave up on the Cine. But we were able to get IR to squirt, and there was nothing immediately, no big bleed that they could immediately embolize. And the orthopedics was able to put a quick X-fix to get our fractures into a stable position where we maintained at least signals to the feet. So that was our next step here. And we obviously elected at this point for damage control and a temporary closure. Sorry about this idle timer. So of the next moves, we've got her steady from that standpoint. She's no longer requiring massive transfusion. Who would go directly to the ICU versus who would go to the scanner? And I think this is a little bit institution dependent, so I recognize that. But
Dr. Hodgman?
If the patient is metastable, I will go to the scanner, no question. There are too many things. You don't know what's happening in the head. patient now is intubated. You don't know what happened with the aorta. There are many other things that can be a problem. It will allow you to evaluate the kidneys. Maybe the hematoma behind the duodenum is a kidney hematoma. And if it's not bleeding, yes, you don't need to do anything. But I have seen cases where they bleed into the collecting system and they have a massive hematuria without really too much of an expanding hematoma, and you need to take the kidney out or embolize. The other possibility is that you might have an arterial injury to the kidney, though you just did an angiogram. So CT scan all the way. And I'm not a big fan of going to CT scan with an unstable patient, but I think if a patient needs to, this is the one. Thank you.
Thank you, sir. Dr. Calderon, any comments?
Completely agree. I need more information. I need to know how does the brain look like, how the pelvic bone looks like, but he still needs resuscitation, continued resuscitation. So I would take the patient to the CT scan, but supported by the main staff for monitoring and resuscitation. That's all.
Thank you, Dr. Calderon. I just wanted to ask a couple more attendings here. Dr. Menegoso, Carlos Menegoso, any comments thus far?
Hi, guys. Thank you. Thank you for calling me. I'm sorry I got here a little bit late. I didn't catch the case, so I'm just hearing and learning with you guys. Thanks, son.
Thank you, sir. Then one more comment here, Dr. Sarah Ashley Ferenz, any comments so far?
Nope, great job.
All right. So we did go to the CT scanner. And we, like you said, the trauma team kind of followed to the scanner, left the room available. I know that's not an option at some places, but I do find that to be incredibly helpful and something that I'll bring along with me, that they leave the room open and ready to go in case you need it coming back from the scan. So she got very lucky. This was sort of the best representative image of the bleeding in her brain, which was small, 5 millimeter bleed that was stable over repeats. Get a good look at her liver here and see how it was pretty devascularized along the area. Obviously, all of our packing is in there, but pretty devascularized along the area of the laceration that we kind of reapproximated that controlled the bleeding. As a view of the kidneys, scanning up and down didn't give you too much. As far as seeing there was no active extravasation in that hematoma by the duodenal sweep, and packing seemed to have controlled that. We did get a CT cystogram based on the hematuria, which showed obvious extrav from the bladder. And the 3D recon was the best way, I think, to see most of the pelvic fractures, but obviously some extensive pelvic fractures that at this point, we had looked on the inside, didn't see a big zone 3 hematoma. IR had already squirted. So we had pretty decent control of bleeding at that point. So from there, we elected to go to the ICU instead of back to the operating room. We didn't feel there was anything else we could intervene on acutely. So in the ICU post-op day 1, actually she did quite well. Corrected her acidosis with some resuscitation, corrected the TEG with blood products, and she was ready to go back to the operating room post-op day 2. So at the reoperation, we were able to, unpack the liver, check it for hemostasis. It needed a little bit more electrocautery on some of the bare edges. The gallbladder did look a little ischemic, so she had an open cholecystectomy. The spleen, Dr. Carter can give more kind of color commentary on this take back, but the spleen, where there was a capsular hematoma before, had broken open, and topical treatments were ineffective at getting that bleeding to stop. So she did end up getting a splenectomy at that point. And we saw some siphonification back behind where that duodenal injury was, so elected for wide drainage at that point. There's some representative images. You can see the on the left side of the screen, the liver laceration that was split wide open that we reapproximated initially with some cautery marks along it there. And then you can kind of get a sense of some of the saponification and potentially a little Kyle leak from the Coker maneuver here on the screen right. Additionally, we did ask urology for some help and went and found the holes in the bladder and repaired those in sort of standard bladder 2-layer fashion, and left a Foley, and then sort of extensively drained the abdomen. And I don't know if Dr. Carter wants to comment here, or if anybody wants to continue.
I mean, I guess I'll add that, you know, this is one of the softest indications for a splenectomy that I've participated in, but I just was not, in this patient of all patients, was not going to get caught trying to do some splenic salvage of any type. And once we were unable to stop this oozing with a couple of different attempts at packing and hemostatic agents, I just figured it was safest to take out.
May I question? Why did you repair the bladder? It was an extraperitoneal bladder rupture.
That's a very astute question. So we didn't highlight all of the, oh, there, yeah, those are good images actually. So her bladder injury was tracking both cephalad into the retroperitoneum, and it was hard to tell whether there was actually rent in the peritoneum and some communication into the intraperitoneal space. And then also it was tracking southward into the space around the femur fracture. And so we figured that orthopedics was going to need hardware for their pelvic fractures and then also for the femur, definitive hardware eventually. And we didn't want to bathe all that in urine over time. And so we felt that this, even though it, you know, typically preperitoneal injuries don't need repair, we thought it would be required in this particular patient.
Thank you.
Can I just ask you, if you have a extraperitoneal bladder rupture in the presence of pelvic fractures, in this case, the inferior pubic ramus, isn't that an indication to repair extraperitoneal bladder rupture?
It sort of becomes an intraperitoneal one in my mind, but that's an inexperienced fellow's assessment. So.
We have had extraperitoneal bladder rupture with pubic ramus fracture, and usually we don't repair. The orthopedic surgeons avoid the area which has drained the bladder. But obviously this is a very extensive one, so I think I totally understand now why they decided to repair. But if it's too big and it's dripping into the leg and you have too many fractures, and it's unlikely to be contained by the tissues because the tissues are all disruptive, I think that maybe treating this as a intraperitoneal really makes sense.
I have a question. Would anybody do a suprapubic and get rid of the Foley?
But what would you achieve by doing a suprapubic cystostomy over the Foley?
That used to be the dictum earlier on, when you have a injury to the bladder, convert it into a suprapubic and get rid of the Foley.
I think that if the urethra is patent and you have a Foley inside, maintaining the bladder collapsed with the Foley would not require a suprapubic, Dr. Kasim.
Thank you.
Thank you.
Dr. Lenine, any comments? You fix these?
I mean, you don't have to fix all extraperitoneal bladder ruptures, right? But what I think the key point here, I think, is it's not really contained. And in order for that to heal, it has to be contained. So.
Yeah, and this is a good thing for this situation where if it's easy to access and it's right there in front of you, then I think that the repair was a good indication on this case, in my opinion.
Yeah,
Thank you.
sure. That's a good point.
Right. So we talk a little bit about her additional post-operative course, but that was sort of the meat of what we wanted to talk about as far as content. She did go back several times to the OR with orthopedics as expected. Was extubated about 6 days after, about a week or so after coming in. Complications were a chyle leak that was managed effectively with a drain, urinary tract infection that was treated effectively with antibiotics. Psychiatric treatment has been promising. This was a suicide attempt. She was found to be, and has had a long history of psychiatric issues, but was found to be profoundly hypothyroid as well. So with that treated and with some of the treatment by psychiatry, she's been doing fairly well. She got out of the ICU on the last of the month, coming in on the 4th, and was transferred to rehab on the 10th, and actually continues to recover fairly well from this, all things considered. I did want to bring up this this chart, sort of what height of fall starts to get your attention for this being unsurvivable versus high probability of devastating injuries. This is some of the more interesting data that I found. This one actually stratified people by what floor as opposed to height. There was a couple of other articles that looked at LD50 and they considered floors by 10 feet, 12 feet. It changes the LD50 a little bit, but somewhere between 40 and 50 feet is the LD50, with the LD90 being somewhere between 80 and 90 feet, which honestly is a lot higher than I thought it would be. So I thought that was interesting. Obviously, the N as you get out to the right on this graph is not a lot of people come in at all after falling 14 stories, I don't think. But it was a higher.
I think it's also important what you hit on the way down.
Yeah.
Like
and which body part hits first. If you get a crumple zone, you might be a little better off than if you go head first off the 7th floor. But that was an update for me. I remember the LD50, I thought was more like 30 feet, and it looks like it's more, as we get better, more recent data showing, 40 or 50 feet is really a 50-50 shot. So with that, thank you all for listening. We can definitely talk through more of the case or look at images if there's further questions.
Hey, John, great case, great presentation. I really like you fellows to taking over this meeting once a month. And that's the goal of the Pan-American Society. Young leadership, young faculty taking over and doing the best for the society. And thank you very much. Congratulations for this amazing case. Same to you, Nick Carter. Thank you very much.
Thank you, guys.